Thank you for joining us on this wound infection education. I'm Jane Mays and I've joined forces with the Tissue Viability team to bring to you the wound infection framework. Prior to understanding what the framework is all about, it's really important that we go back to what is wound infection. Simply, wound infection is the presence of bacteria that overwhelms the patient's immunity. So quite simple, that is what wound infection is. And it's really important as clinicians that we can recognise early wound infection. The most important element is preventing the infection in the first place. We really do need to carry out holistic wound assessments on our patients. The way that infection develops, it's the virulence of the microorganisms, their ability to cause disease, that some are more virulent than others. And then, most importantly, it's the patient's immunity. That's what will get on top. That is what will get on top of that patient's wound infection. Those important white blood cells need to get to the wound to manage wound infection. So we need to focus on maximising the patient's own immunity status. And then obviously the presence of devitalised tissue. Great environment for bacteria to multiply and replicate. So good wound bed preparation through wound assessment is vitally important. Along with wound exudate. You need to manage the level of exudate. Wounds love wet environments. Bacteria multiply and replicate very easily in that environment. So home in on your patient. The message today is look at the patient holistically. Can we maximise and really optimise those patients' underlying diseases? Make sure their diet, nutritional status, fluid intake are all maximised through your assessment ability. Sadly, as we get older, our own immunity does decrease. So that is something to be aware of in that older population. Other factors that can compromise a wound and increase its risk of infection are the environment, cross-contamination can be an issue, lifestyle choices, smoking, alcohol intake, stress, all increase the patient's risk of developing a wound infection. Some of those medications that we take and patients take can suppress the patient's own immunity response. So it's holistic assessment that needs to be focused on. When an infection does occur, as healthcare professionals, we need to be able to recognise it really early on. And the infection continuum helps us do that. The infection continuum was developed by the International Wound Infection Institute. It's a tool that helps us recognise early when a patient's wound is infected. Right down at the bottom here, contamination. All wounds are contaminated with bacteria. That just means there's bacteria there. A break in the skin, it's always going to have a large number of microorganisms present. Colonisation is when the number of bacteria has increased, as you can see on this diagram by the graph increasing, and they have divided, multiplied and replicated, but they're not causing damage to the wound or the patient at this point. There's no indication of wound infection. This is the point, localised infection, that we really do need to be mindful and very vigilant around. This is where that level of microorganisms has overwhelmed the patient's wound and is now starting to cause an issue to the patient and their wound. So the signs and symptoms of localised infection, that balance is wrong. There's more microorganisms than the patient's immunity cells, so the balance is out. So it's overwhelming. They're winning the party. They're overwhelming the wound. The patient will present with signs and symptoms such as an increased amount of exudate, and there may be some discharge and odour. The wound may appear a lot warmer around the edges, and the patient will say to you, it's more painful than it was. Always listen to what the patient's voice is telling you. There may be an element of breakdown, undermining, a delayed or normal process that you would have expected with that patient's wound will have occurred. With regards to erythema and redness, we're brought up to know that that is a sign of infection. It's really important to recognise that in those dark skin tones, this can be really difficult to see. So be aware of that during your wound assessment. We need to act at this point of localised infection, and Kate will go on to explain the wound infection framework for Leeds and what to do when we recognise localised infection. Because ultimately, if that level of bacteria completely overwhelms the patient's wound and the surrounding tissue, we get an element of spreading infection. And the patient at this point is starting to feel unwell. They may say they have flu-like symptoms, and they'll have all those localized symptoms as well, but the patient's now immunity is really struggling. And obviously, if we then continue on this journey and the patient's wound and the patient themselves is overwhelmed by the bacteria burden, we get an element of systemic infection. It's at this point that the patient is really unwell, and there's guidance in the infection framework around if you should see these elements of spreading and systemic infection, what you should do. Ultimately, we have to be mindful that that patient is at risk of that horrible word sepsis that we're all familiar with. And sepsis it happens to a patient when the patient's immunity system overreacts to an infection, and that infection starts to damage the patient's own body and the tissues and the organs within the body, and ultimately can be fatal to that patient. So hopefully this infection continuum that we've explored will really support you in your decision making, and the wound infection framework is built on this infection continuum. So I'd now like to hand over to Kate Williams to go through what the wound infection framework is telling us and how to use it in clinical practice.
Hi, I'm Kate Williams. I'm a senior lecturer at the University of Huddersfield in tissue viability, and I'm also an honorary tissue viability nurse here in Leeds. So I want to show you now the Leeds Community Healthcare Trust wound infection framework. So we've got version 2. So the way you'll tell the difference is that there's a slight lilac colouring to the left side of the framework, and it says version 2 on the top, but it's really clear that you know that there's now 2 versions. This replaces the previous version. The other one is now null and void. So just to follow on what Jane's been talking about, we've done this around that consensus document that Jane was talking about, the International Wound Infection Institute document. We've pulled out the most important points. So the most important points is that you are able to recognise signs of local infection and act on them quickly. You've got the products in the cupboard. If the Prontosan isn't in the cupboard already, it will soon be. So they will be on stock on shelves. But the main thing is that you know what you're looking at and that you recognise these signs of local infection on the left-hand side. So hypergranulation or overgranulation, you might hear it called. Epithelial bridging, so tiny little thin bridges, or it's very rare that you'd see that, but you might see little pockets in granulation tissue. You do see, I know you see a lot, bleeding of friable granulation tissue. So that's when it looks red. It might be a bit dark red, like not a good healthy red granulation, but a little bit dark. And when you clean it, it bleeds a little bit. That is enough to start this framework. We want to act at that point, because that is a sign of local infection in the wound, and we want to deal with it. Delayed wound healing from expectations, new or increased pain, malodor, erythema. These are kind of more typical signs. But this is at the point where I want you to start using the Prontosan soaks and Cutimed Sorbat. So Cutimed was on our previous framework. You'll be familiar with it. Zoe's going to go through Cutimed just to make sure that you all understand how it's used and how it works. But the addition to this version 2 is Prontosan. Some of you who are really familiar with wound care and much more into wounds than others will know that there is an option of a debridement pad in this kind of care pathway, but we've chosen not to do that at the minute because we want to see what we can achieve with just this. So for now, we are just cleansing as thoroughly as the patient is able to tolerate with Prontosan. Daniel's going to go through Prontosan, so I'm not going to talk too much about that. So you start the pathway, you start Prontosan, you start the Cutimed Sorbat, and then you review in 2 weeks. And it's self-explanatory from then. If it doesn't improve in 2 weeks, look at other signs, look at other antimicrobials rather, use silver, iodine, whichever either you or your district nurse or your link nurse or whoever you go to for wound advice recommends. So that's the left-hand side, that's the signs of local infection. On the right-hand side, is if the patient has spreading infection and systemic infection, and these are the patients who need antibiotics. So this is where they've got hardness and redness that is spreading up the leg. This is very different to chronic red legs, you might say. So chronic red legs you see in lymphedema, it's not hot, but it is swollen because the whole legs are swollen. So just be very clear on your assessment. Is the leg really red, and is it hot? Is it one leg or is it both legs? Because both legs is really rare. Lymphangitis, so that's like little red lines that can track up the leg. That is really serious. We know the patient needs antibiotics if they have that. Crepitus is something you'd rarely come across, so that feels like crackling, almost like bubble wrap under the skin. That's a really serious side of infection, and that needs escalating. So all these things on the right-hand side need escalating. You need to consider sepsis. You need to consider all the deteriorating patient works. You need to be doing news too. So you complete a full set of OBS. You complete the sepsis screening tool. You clean the wound and take a swab, because we know these patients are going to need antibiotics. Dressings-wise, it's the same, whether it's local or systemic infection. The difference is patients with systemic infection need closer monitoring. They need observations, news scores, antibiotics, liaisons with GPs or senior staff. One thing else to consider, however, is the source of infection. So if the patient is clinically unwell, could it be that they've got an infection from another source? So could it be a urinary tract infection or a chest infection? If so, collect samples as appropriate, it says there. So the framework itself, none of that is new. That's all on the previous framework. The only change really for you guys is the adding in the Prontosan, but Zoe and Daniel will go through so that you understand how to use the products properly. But the one point I haven't mentioned yet is that little red circle in the middle, which again was on the first version. And it's just to bear in mind that immunosuppressed or diabetic patients might need oral antibiotics earlier. So they might not get that typical infection response that you or I might get. So please bear in mind, you need to look at the patient's history. Are they diabetic? Are they immunosuppressed? Because they may need antibiotics earlier. But that's a discussion for that you'd have in handover, a discussion with a senior nurse. You don't need to make that decision in the house. So if you're not confident with this, start the framework, discuss it with a senior clinician and come up with a plan for that patient. If you could also do a set of OBS if you're not sure. It's best to do a set of OBS when not needed than not do a set of OBS when needed. So yeah, it's not a huge change from the version 1 of the framework, but I can't miss the opportunity to talk to you about sepsis awareness. Couldn't help myself, sorry. So this is also coming out with the framework. It's going to be on System 1 on a tab. It's also on the back of the paper copies of the framework, and it's just a cleansing guide, just to remind you how long we need to use Prontosan for. Daniel's going to go through that in much more detail, but you'll see this around. And I appreciate that a 10 to 15 minute soak in a very busy team can be really difficult to achieve. So it's about planning your visit. It's about taking the dressing down and then applying the soak and then doing all the other things you need to do while it's soaking. Just try and plan things so the soak is on there as long as possible. But I do understand that a 10 to 15 minute soak can be a challenge. But please try and organise your visit so it's possible. And then this is a poster that you're going to see around, just to remind you really, because cleaning wounds sometimes doesn't happen, whether it's just habit or whether it's just people so busy. But they all need cleaning, and they all need cleaning thoroughly as the patient is able to tolerate. I appreciate not all patients are able to tolerate it. But I'm going to hand you over to Zoe and Daniel now, and they will talk about the products so that you really understand how they work, so that we know we're using them properly. Thank you.
Hello, my name is Daniel, and I'm the company representative for B. Braun Medical. Over the next 5 minutes or so, I'll be providing a little more detail around Prontosan's solution, covering why it's an important part of wound bed preparation and how it works, specifically for those local and spreading infected wounds. As you likely already know, wound cleansing is an important aspect of basic wound care. However, the rationale for cleansing can vary depending on the wound condition and treatment objectives. General reasons for cleansing can include softening and removing slough and debris, making wound assessment easier and more accurate, removal of exudate, and of course, reducing bioburden and biofilm in the wound to prevent and manage wound infection. But what actually is a biofilm? We know that over 90% of chronic wounds contain a biofilm, and compared to planktonic free-floating microorganisms, which are relatively easy to remove, bacteria in a biofilm group together and develop a thick, slimy barrier of sugars and proteins, and we call this the EPS. This barrier shields the bacteria and fungi from antimicrobials and the patient's natural immune system. For a really simple analogy of EPS in a biofilm, I always like to imagine that the bacteria put up a protective umbrella which shields them and allows them to continue growing and multiplying. Colonization of a biofilm can happen within 2 to 4 hours, and we start to see the inflammatory host response within just 6 hours. If we don't do anything to remove the bacteria and break down the EPS of a biofilm, they can quickly become a source of wound infection. So what makes Prontosan solution effective at removing biofilm and managing infection? Other than purified water, there's 2 really key ingredients in Prontosan. The first being PHMB, which is a broad spectrum antimicrobial that has really fast onset effects at killing bacteria, but also has a balanced efficacy and tolerability rate. It also means that you can continue to use the same bottle of Prontosan solution for up to 8 weeks. But the most important aspect of Prontosan is betaine, which is a surfactant and that aids better cleansing. It works by physically pulling apart the biofilm and the EPS, removing it from the wound and carrying it in the solution. You can see how this works in the video.
One to 1.5% of people in industrial nations suffer from chronic wounds, such as pressure ulcers, vascular leg ulcers, and diabetic foot ulcers. Besides being a high burden on the patient, these wounds also generate high costs for the healthcare system. But why are chronic wounds such a challenge? Wound infections are a major factor. It is estimated that more than 50% of all chronic wounds are infected. Wound infections are caused by microbials such as bacteria, which do not only like to multiply, but they also produce biofilm. Biofilm forms when free-floating bacteria adhere to surfaces and grow a colony. This colony excretes a thick and slimy substance, an extracellular polymeric substance which consists of polysaccharides, protein, and other elements. Biofilm can also release bacteria which form new colonies in nearby areas. The biofilm acts like a shield for the bacteria and protects it from many antimicrobials, including antibiotics, and from the host's immune system as well. So there is a constant threat of a chronic wound infection. To prevent the development of wound infections and to promote wound healing, it is important to remove the biofilm and achieve an effective wound bed preparation. The Prontosan range provides a smart solution to effectively cleanse the wound of biofilm, slough, and debris. Moreover, the special combination of ingredients reduces the biofilm and also impedes its reformation. The 2 main ingredients in Prontosan solution are polyhexanide and undecyleniamidopropylbetaine. To keep it simple, we call it betaine. Betaine is a surfactant. Let's have a look at how a surfactant works. A surfactant molecule basically consists of a hydrophilic, water-attracting head and a water-repelling, hydrophobic tail. Since the tail doesn't like water, it searches for another place to go, which here is our biofilm. The polar heads of these surfactant molecules have the same electric load and therefore they repel each other. This is how the biofilm breaks up. Several of these surfactant molecules bind to the biofilm and build micelles, which can then be removed from the wound bed much more easily. In this way, betaine has in essence opened the door for the supportive effect of polyhexanide in Prontosan, which can now act against the bacteria. Polyhexanide, or PHMB, is used as a disinfectant or antiseptic. It is able to attack and destroy various types of microorganisms. Gram-positive and gram-negative bacteria are protected by a cell wall, whereas human cells are surrounded by a cell membrane. These bacteria can cause serious diseases and are resistant to antibiotics and antiseptics. A bacterial cell wall has a negative charge, while the PHMB molecule has several positive charges, which makes PHMB act like a magnet, attaching itself to different areas of the cell, starting with the negatively charged outer cell wall. PHMB binds itself to the cell wall through electrostatic interaction. The cell wall breaks open and begins to leak where the PHMB molecules attack. This results in the cytoplasm exiting the cell, which quickly causes the bacteria to die. PHMB attacks, breaks down, and destroys bacteria. Due to its positive charge, it also supports the barrier effect on the wound, as it prevents bacterial cells from adhering to the wound surface. No bacteria, no pathogenic biofilm. In summary, betaine breaks up biofilm and opens the door for polyhexanide to act against bacteria and to interfere with the reformation of biofilm. That's why Prontosan is the smart solution, not only for an effective wound bed preparation, it's also the first choice to prevent wound infections.
And to have that effect on biofilm, the ingredients of Prontosan require time to break up and remove the bacteria from the wound bed. As Kate mentioned, the wound cleansing guide can be a really helpful tool to identify the recommended soak time depending on the wound condition, volume of slough and exudate, and you can adapt that depending on the wound condition. Again, it's more about planning your visit to ensure that you've got enough time to invest on that wound bed preparation aspect. Getting the Prontosan soak on the wound straight away while you prepare your dressings and take patients' notes, etc. To allow that surfactant of Prontosan to really soften any slough, break down the EPS and remove the biofilm, soaking is recommended. More often than not, this is done by irrigating 20 to 30 mils of Prontosan solution onto a few pieces of gauze, placing it on the wound and allowing it to soak. Giving Prontosan that time to soak allows the solution to reach those lower levels of bacteria living at the very bottom of the wound. And an irrigation really can't reach those parts. If you are keen to keep up to date with the most recent clinical evidence, product information, and future webinars, please join our educational newsletter by scanning the QR code. But if you have any questions right now, please direct them to your local representative or email woundcare.uk@bbron.com. Thank you.
Hello, I'm Zoe, S&T Account Manager, and I would like to take the opportunity to run through some Cutamed Sawback information with you to share. So some of you might already be familiar with Cutamed Sawback, so it might be a reminder, but for some of you that are new to the trust, this might be new information. So I'm going to cover three aspects. I'm going to talk about how it works, so talk about the Sawback technology. I'm also going to talk about benefits for your patients, and then I'm going to finish with just reminding you about the two different variants that are available to you within the Leeds area. So Cutamed Sorbat is safe, simple and effective infection management. It's a topical dressing of choice and it works in 3 distinct ways. So it binds, inhibits and removes. So bind, all of our dressings have a DAC coated surface. So all Cutamed Sorbat dressings have the DAC coated onto their surface. This has quite special characteristics and hydrophobic properties. The bacteria naturally binds and anchors to this unique Cutamed Sorbat surface, and also this binds endotoxins that may impair wound healing. So it inhibits. So not only does it bind, it inhibits the bacteria. So we know that they are irreversibly bound, so that growth is completely inhibited. Endotoxins are shown not to be released from the bacteria. So no mechanism of antimicrobial resistance has been described with Cutamed Sorbat. It is then removed. So the bound bacteria that has been inhibited, and that includes bacteria and fungi, and those endotoxins are safely removed. So the bacteria load within that wound bed is significantly reduced. So the reduction in bioburden supports natural wound healing. So I've talked about how Cutamed Sorbat safely removes bacteria. So there's kind of 3 key elements to that. We know the bacteria naturally binds to and anchors to that surface, and we know that no antimicrobial agents are released into the wound bed. So therefore, the development of bacterial or fungal resistance is not expected. So we have a range of benefits for Cutamed Sorbat for your patients. So some of these we've already mentioned, but we know that it does not promote any bacterial release of endotoxins. So that promotes natural wound healing. And then we know that we can use the dressing it's suitable for prolonged treatment use. We know that there's no release of agents in that wound bed, and that is key to the development of bacterial or fungal resistance, as that is not expected. There is no contraindications to use this dressing, and there is a very low risk of allergies, so it's suitable for all patient types. It reduces the bioburden within the wound bed, and also it is immediate onset of action. So from the moment you're doing your wound cleansing and you're applying your dressing, we know that this DAC technology is immediate. So the moment it makes contact with the wound bed, we know that starts to take action. So to remind you of the 2 variants, we've got Cutamed Sorbat swabs, which do come in 2 sizes. So we have 4x6 or 7x9. So really good to have a choice when you're doing your holistic assessment as to which size would be more suitable for your patients. So this is an acetate primary wound contact dressing, and it's suitable for all wound types. We also can use this for skin folds, groins, or maybe in between digits, so fingers and toes, particularly suitable for fungal infections. Really key when you're opening your packets, because you'll note that these are folded sizes. When you take the packet dressing out of the packet, we do advocate making sure that you're putting a single contact layer as your primary dressing to your wound bed surface. So you will notice here there's some unfolded sizes to give you a gauge of what size would be most suitable for your patient. We can cut the swab, we can cut this, that's no problem, but we do recommend leaving as a centimetre border around your wound bed, so obviously greater than your wound bed size. It can be left up to place for 7 days. Obviously that would be dependent on clinical judgment, the degree of contamination and the exudate levels. So then moving on to the ribbon. So the ribbon is a cotton ribbon for deep cavity wounds, and that comes in 2 sizes too. So you have 2 centimetres by 50 centimetres or 5 centimetres by 200. Indicated for, again, suitable for skin folds, groins and digits. Really a soft dressing to apply for digits and toes. And also we know that this is exactly the same. So The key message for this is it can be used up to 7 days, but again, you would be using your clinical judgment in regards to exudate levels and also degree of contamination. So all of our Ketomed backed boxes comes with instructions for use within the packet. However, if you feel that you need any additional product information, any support, or any further educational sessions, please feel free to contact Essity.
So thank you for joining our education. Hopefully now you feel empowered and supported in recognising wound infection and the management process using the Leeds Wound Infection Framework. Thank you.